like to introduce our next speaker, Dr. Gati. He's a cardiologist at the Royal Brompton Hospital and a specialist in cardiac MRI in athletes.
Thanks, Maria. Okay, hello everyone. Welcome to this conference and thank you for the invitation to speak on when to worry about scar on cardiac MRI. So cardiac MRI has become widely available over the last decade or so, and whilst it's unlikely to replace your relatively inexpensive portable echocardiography, it does have its benefits in certain patient cohorts. For example, for the evaluation of cardiomyopathies, to check for inflammation in myocarditis, to check for your subtle regional wall motion abnormalities and fatty infiltration, but also the extent and patterns of scar, which allow us to assess the etiology of the condition, risk of heart failure, and arrhythmic sudden cardiac death. Now, there will be certain situations in where the echo is completely normal and the sports teams may call upon the services of the CMR unit, or you may decide to proceed directly to a CMR in your athletes who may demonstrate T-wave inversion on their ECG, ST segment depression, Q waves, possibly small limb lead complexes, left bundle branch block, and ventricular arrhythmias. When would I not worry about a scar on CMR? Certainly athletes with insertion point fibrosis. So minor focal fibrosis, that's within your RV insertion points, papillary muscles, and RV trabeculae, has been identified in around 44% of athletes as compared to less than 11% of controls. And what this simply represents, the RV insertion point fibrosis, is a benign consequence of chronic exercise, so trauma from mechanical stretch. When would I worry about scar on CMR? So I'd like to go through a few cases with you. So myocarditis accounts for 5 to 22% of sudden cardiac deaths in the younger population, and the incidence of sudden cardiac death is even higher in the context of exercise in cases of myocarditis. So here we have a 40-year-old male white cyclist who presents with pleuritic chest pain. ECG is normal, doesn't show any concave ST changes to give us some clues. Troponin was mildly elevated, and the echo demonstrated a trivial pericardial effusion. The team referred the individual for a cardiac MRI, and I think rightly so, because actually his MRI showed that he had active ongoing inflammation in the basal infralateral territory on his T2 stir imaging, which was beautifully quantified on his T2 mapping, and he was also identified to have necrosis on his late gadolinium. So the take home here is that if you have a high suspicion of myocarditis in your athletes, do a CMR. That's probably going to be your best test that you're going to do. If you find the inflammation, then you need to restrict these individuals for a period of 3 to 6 months and then repeat their evaluation again. If they've got ongoing inflammation or impaired LV function, again, you need to give them the exercise advice. But if their MRI is normal with no inflammation, good LV function, and their other tests are normal as well, then they can go on to compete in all sports. If they've got stable or declining late gadolinium and a normal LV function, you need to make a case-by-case decision. We keep them under surveillance. And those with extensive late gadolinium, so I'm talking about more than 20% of the LV myocardium, or they've got LV impairment, then the advice is abstain from high-intensity exercise. So what's the potential information that we can derive from the late gadolinium? Certainly in the absence of late gadolinium, it's associated with an excellent prognosis. For every 10% increase in late gadolinium that you see, there is around 80% increase in MACE. The distribution matters. A patchy distribution is associated with a threefold increase in risk. And locations and patterns matter. So an anteroceptal pattern or a mid-wall distribution, it has also been associated with increased risk. And this is important information we should give to our referrer. He comes back for a repeat evaluation. His LV function looks great. But look at that, he's got extensive patchy mid-wall fibrosis in several territories. And on further assessment, he was also identified to have some non-sustained VT. So it's this sort of a picture that would make me worry. But what have we got from the MRI? We've identified his etiology, we've identified whether there's ongoing inflammation, his LV function, but also to check for extending scar on serial MRIs, because not all scar in the lateral wall is secondary to myocarditis. Now, the Bart's group looked at lots of people with genetic forms of cardiomyopathy, and what they found was that a circumferential distribution or subepicardial fibrosis in the lateral wall was common with specific genetic forms of cardiomyopathy. So, for example, your desmoplakin cardiomyopathy, which is probably the second or the third most common cardiomyopathy, was associated with a circumferential distribution with a subepicardial pattern. Another example is euphylamine C. It's another aggressive form of cardiomyopathy, and it was associated with subepicardial fibrosis in the lateral wall. So my take-home message here is that we need to be careful not to label certain cases of myocarditis because not all lateral wall scar is due to this. And so you need to keep an open mind to the differential diagnosis, and this is where serial imaging does become important. Moving on to the next case. So we often get referred, is this athlete's heart or dilated cardiomyopathy in our sports cardiology services? So here's a recreational cyclist with a reduced exercise tolerance, didn't have a family history, his ECG showed athletic changes, his left ventricle on MRI was mildly dilated, the function was mildly reduced, but look at this, on late GAD, unexpectedly, he had mid-wall fibrosis in his septal wall. And this is good going mid-wall fibrosis. And this makes life very easy for us. We know his etiology, but we do this for risk stratification purposes. So why does scar matter? Why do we spend so much time looking at it? So according to Gati, the presence of late gadolinium enhancement was associated with the occurrence or aborted sudden cardiac death. And this makes sense. The presence of late gadolinium represents replacement fibrosis. And so when the electrical currents are passed through the myocardium, they slow down in regions of fibrosis, creating reentrant circuits. This can cause VT, and this is the most common cause of sudden death in this group. Now, Halliday looked at whether the amount and location of late gadolinium mattered in predicting sudden cardiac death. So he took 800 patients with dilated cardiomyopathy and divided them into 4 groups. So those with no fibrosis, those with mild fibrosis, those with moderate fibrosis, and those with lots of fibrosis. And he measured the hazard ratio based on the extent of late gadolinium. And what he found was that with small extending increases in fibrosis, there was a step-up increase in risk, which then seems to plateau. So it may not be about the amount, but the presence or absence of fibrosis that may be more important. He then looked at the locations and patterns of scar. And so to put it in a nutshell, if you have a septal distribution or you have multiple patterns, so mid-wall and a subepicardial distribution, that's associated with a high risk. And this, as MRI doctors, we should relay to our referring team. This is important information we need to give them. Let's talk about the next case. So here we have a 35-year-old runner who presents with palpitations and a family history of cardiomyopathy. And this is what his ECG looked like. So if you see an ECG that looks like this, where the ectopics are coming from the left ventricle, even if the MRI is normal, you should be thinking about doing an MRI scan. Your differential diagnosis includes the non-dilated left ventricular cardiomyopathy, which is hot on the topic at the moment with the ESC, which includes certain genetic forms of cardiomyopathy, but also includes your scar in keeping with the left ventricular dominant form of arrhythmogenic cardiomyopathy. So you can appreciate in his scan, his ventricles dilated, his ejection fractions reduced, his lateral wall looks a bit thinned out, and he's got extensive fibrosis. So the autopsy data on 5,200 consecutive sudden cardiac deaths from the UK Cardiac Pathology Registry found that 4% were diagnosed with arrhythmogenic cardiomyopathy. Now, when they dissected their hearts, biventricular involvement was identified in 70%, but left ventricular involvement was identified in 17% in addition to the RV involvement. So what I'm trying to emphasize here is that AVC can present in a variety of ways, including your LV dominant forms, and we also now know that visual assessment of myocardial fibrosis is associated with a 5-fold greater risk in ventricular arrhythmias as presented in this later study. So over the past few decades, marathon running and triathlons and Ironman have become increasingly popular with individuals in their 5th decade onwards. And we're hearing reports of high concentrations of biomarkers of cardiac damage, transient LV dysfunction, and possibly associated with substrates for arrhythmogenesis. So Megrani and Maestrini looked at 158 veteran athletes. 44% had myocardial fibrosis, of which the vast majority was in the insertion points. Major focal fibrosis was identified in 11%, that's within the compacted myocardium. Age was an independent predictor. It was more common in males than females. A third had an ischemic pattern, and the vast majority had a non-ischemic pattern. And whilst we don't understand these fibrosis patterns in this sort of a cohort, I think we need to evaluate them for arrhythmogenesis until we have longitudinal data available. So my gems from this talk are: minor focal fibrosis is common in athletes, and it's located in the right ventricular insertion points. We certainly use CMR to investigate certain ECG changes, as I've highlighted here. CMR can be helpful in the identification of acute inflammation in cases of myocarditis. CMR can also be helpful in assessing the extent and severity of scar for risk assessment and other potential complications. Major focal fibrosis is present in 11 to 17% of middle-aged endurance athletes. Its precise significance is still unclear. We need to gather longitudinal data, and this is where registries will become really helpful. Most athletes have a non-specific, non-ischemic pattern of major focal fibrosis, but a small proportion may demonstrate features compatible with myocarditis or limited myocardial infarction. I think it's really important that we clinically correlate the myocardial scar and don't just use it as a sole reason that we see what we see on MRI as a reason to restrict or disqualify an athlete. Thank you very much.
Excellent talk. Thank you very much. Any questions from the audience?
Sabir, great talk. Thank you very much. I just want to highlight not the CMR here, but you pointed out in this one patient the myocarditis and the recommendations on exercise for 3 to 6 months of no exercise. I would like to put up this point that exercise is from resistance, coordination, yoga, and endurance as well, certainly. And I think now and in the future, at least this way, what I do with my patients is to differentiate between the modes of exercise. And it's clear that endurance exercise and high exercise intensity is not something we could recommend, but resistance exercise is something I think we could introduce in some and clinical aspects and so well in the future more than we currently do just by restricting exercise overall.
I agree. I think it's important that the inflammation settles first, Martin. So I think it's the inflammatory aspect that worries me the most. I think once that's settled, then yeah, we should be, obviously it's a long time to wait, 3 to 6 months before they can really get back into their intensive sessions. So yeah, think outside the box and think of other strategies of the way they can exercise without pushing their heart rates up to their max. Yeah, so I totally agree.
One more question.
Yeah, great talk, thanks. One of the difficulties we have when we see athletes with a significant myocardial fibrosis, like you said, they have an increased risk of sudden cardiac death. And although we don't restrain them all the time, it's really difficult to know what patient will have an arrest. So what do you suggest how we have to monitor them to predict the ones who get ventricular fibrillation and the ones who don't, if we don't restrict them?
So I think it's important that you see them on a yearly to 2 yearly basis. You inform them that if they have any symptoms, that they alert us on that basis, because symptoms is important. When I see them in our service, I see them. It depends on what degree of scar I see and where I see it. But when I do see them, I do an ECG, an exercise test, and a Holter ECG. That's my basic. In terms of assessment, I don't necessarily do scar assessment on a yearly basis. I may bring them back for a non-contrast CMR assessment, and if I see a change on that basis, then I may do scar assessment in those individuals. That's how I do it.
Thank you very much.